terzo anno MD che oggi presenterà Corneal Cross-Linking a Revolution in Keratoconus Treatment. Quindi sentiamo.
So good afternoon to everyone. I'm Federico Sivilotti and I'm a sixth-year med student at MD program. And today's presentation is going to be Corneal Cross-Linking a Revolution in Keratoconus. So if you have any kind of question, doubt, whatever, please feel free to interrupt me at any time and please ask any kind of question. So first of all, we have a brief outline. We start with a brief introduction on keratoconus, and then we move to the topics of today's discussion, which is corneal cross-linking. As you can see, there are different types. We can see the epioff, transepithelial, and ontophoretic, which again is a complicated word, it's a complicated term, but we'll get to that in a second. So first of all, keratoconus. Is keratoconus. Keratoconus is a disease of the anterior part of the eye, of the cornea, which, as you can imagine, it is characterized by this cone-like deformation of the cornea. It is coming from the Greek word kerato and konos, which is referring to cone, and it is characterized by this kind of thinning and protrusion of the cornea. So the prevalence in males and females is equal, and the estimated prevalence is around 5.4 per 10,000. Even though we have to remember that the keratoconus is an emerging disease, and it is really interesting to know that the prevalence is largely underestimated because diagnosis, especially in the early stage, is only by some specific methods like anterior chamber or CT. So when we imagine the patient with keratoconus, we imagine a patient is young, is probably in the second to the fourth decade, and is a young patient, typically has also family history of keratoconus. And it is a disease that is asymmetric and it tends to be bilateral, so it tends to evolve to a bilateral situation after many years. First of all, we have some brief introduction on the corneal anatomy, just a few words. So as you can see, the corneal anatomy is characterized by an external layer, which is the epithelium. Then we have the Bowman membrane and the stroma. So the important aspect to remember is that, first of all, the epithelium, the eye is an important barrier in between the external world, which is characterized by the, let's say, the external environment, and the internal world, so the skull and the nervous system. So for this reason, the epithelium plays a crucial role because it has the important role of providing a barrier in between the external agents, including toxins or pathogens, infectious disorder, and the internal world. And also at the same time also protect from the UVA light and protect also from any kind of insult to the cornea. Then we move to the Bowman's membrane, which is at the moment the function is not very well known. And then we have the stroma. So the stroma will be the main focus of today's lecture because in keratoconus we have the formation of different fibrils. In particular, at the level of the stroma, we have different collagen types, protoglycans and glycosaminoglycans, which have a specific shape that is leading to the linking of the fibers. So the arrangement of the stroma is crucial for the maintenance of the mechanical properties of the cornea. So one of the most interesting aspects of the keratoconus is that we have this hypothesis. So at the level of the epithelium, we have the production of some proteolytic enzymes, which then are released and they get into the stroma. At the level of the stroma, they cause a rearrangement of the fibers, reduction in the rigidity of the fibers, and really interesting, we have also disruption of the characteristics of the corneal epithelium. So up to here, everything seems to make sense. And it seems to be so easy. But actually, keratoconus is a really complex disease. Keratoconus, indeed, it is, as we can imagine, it is characterized by different alteration. On one side, we have the proteolytic enzymes, as we said before. On the other side, we also have different other involvement, both at the level of the pro-inflammatory cytokines, like interleukin-6, but also the level of the decrease in the anti-inflammatory cytokines, like interleukin-10. As we said before, collagen is a fundamental precursor, is fundamental for the stroma. And so we might expect that in diseases like Marfan syndrome or collagenopathies in general, an alteration in the structure of the collagen also is a predisposing factor for the development of keratoconus. So we said there are some biochemical factors that we said before, the proteolytic enzymes, the pro-inflammatory cytokines. We have a disruption at the level of the collagen with important genetic consequences. In fact, there have been several studies evaluating the presence of a genetic mutation at the level of keratoconus. But actually, it was shown that none of these genetic associations were associated with the higher risk of development of keratoconus. In particular, SOD1, for example, was studied. but SOD1 had no association with developmental disease, and also there's been only one case report of an Ecuadorian family in which there was a mutation in DOC9 gene leading to the development of the disease. However, this is just an anecdote. There is no basis for the disease in general for the population. So as we said before, complex disease. We have genetics, we have biochemical factors, but also we have environmental factors. In particular, we have to mention different factors like atopy. In fact, it has been known that there is an interesting association between keratoconus and other autoimmune and immune-mediated diseases, like Hashimoto thyroiditis, for example, and also UV exposure, for example, and eye rubbing. So eye rubbing has been associated with an increase of the risk of developing keratoconus. So as we said before, we have a typical keratoconus patient with familiarity, maybe is also an atopic disease. And this kind of patient is coming to the clinic with this kind of appearance. So as you can see, so we have an ophthalmologist that is asking the patient to point downwards with the eyelid. As you can see, there is this kind of V-shaped deformation of the lower eyelid, which is related to the typical conical shape of the keratoconus. So this is one typical clinical aspect. And this is, of course, proportional to how much the disease is advanced. Because in more advanced disease, we also have a greater protrusion of the lower eyelid. But also we have other clinical signs. So in this case, we're using a light on the temporal side of the cornea. And as we can see, there is an interesting bright light on the nasal side. So I'll show you. On the nasal side of the cornea, which is related to the conical deformation of keratoconus. And this is also known to be the Rizzuti sign. There's this beam of light on the nasal side. Also, remarkably, when we talk about keratoconus, we just imagine an alteration in the shape of the cornea. Maybe we are thinning in some specific areas, but we'll get to that in a second. But we do not think about iron. But actually, there is also an interesting iron deposition, which is typical. And this line here is typical of keratoconus, and is also known to be the Fleischer ring. And is related to the deposit of iron on the level of the segment. We have other signs that I'd like to show you. So here we have a normal control eye. As you can see, there is this light. It is pointed towards the eye of the patient, and the vertical line is straight. There is no deformation in the line. But then we have a patient with keratoconus, and as you can see, there is this kind of scissor-like appearance with the two blades of the scissors. And it is related to the apical deformation of the cone. And this is quite pathognomonic for keratoconus. Then we have another sign, which is the Charlot sign, also known as the droplet sign. Again, as you can see, we are pointing lights toward the central part of the cornea. And there is a bright light that is represented by the conical parts, the apex. And then we have a part that is darker and is found on the peripheral side, as you can see. Then we have also other signs which are less typical. For example, the Vogt striae, which is related to vertical signs in the Deschamais. And also we have the increased visibility of the corneal nerves related also to the use of the contact lenses in patients with keratoconus. So diagnosis. As we said before, the incidence of keratoconus is largely underestimated because of the fact that at least in the early stage is almost asymptomatic, and maybe the patient can refer some degree of decrease in the visual acuity. And so at least in the early stage, the only way to get a precise diagnosis is by means of some specific imaging tools. Particularly we have the shampoo imaging and the anterior chamber OCT. So we have some specific images that I'll show you. We'll get this kind of images. Again, here we have maybe complex images, but the concept that I'd like to stress is that the red part is related to an area with an increased steepness of the curve. So it is an area with a greater curvature compared to the rest of the cornea. And this area is typically found in the central parts or at least in some cases can be also in the inferotemporal side, so laterally. This is the more temporal side. This is more nasal. And typically there's also thinning at the level of the cone. Then we have different parameters that by means we can evaluate the progression of disease, which is K1, K2, AK, but again, this is a quite specialistic topic. For when it concerns the staging, just a few words. The two most important classifications are the AK staging and the ABCD criteria, which are based on the AK staging is the traditional one, is the classical one. It's based on the visual acuity, on the keratometric values, like AK. The degree also of astigmatism is fundamental for the development of the disease as well. We also have a more recent criteria, which are the Berlin ABCD criteria, which are based on the anterior curvature, on the posterior curvature, and also on some subjective values like the visual acuity, and also the thinnest also part of the cornea. That is measured typically by pachymetry. So we want to evaluate the shortest, the thinnest part of the cornea. Okay, so we have a patient with keratoconus. We want to treat the patient. And here we get to the most interesting part, because in fact we have different options. The first line option, I would say, that is the use of contact lenses, in particular the RGP lenses, so gas permeable, but typically they're used for a patient in the early stage. Otherwise, we can also use the hybrid lenses or the scleral lenses, which are used for, let's say, more advanced cones. But the problem with all these kind of options is that it is not blocking the progression of disease. As we said at the beginning, keratoconus is a progressive disease. It is getting worse up to the 4th decade. And in the most severe cases, it's also leading to some really invasive procedure like penetrative keratoplasty, which is a procedure which is associated with an important risk of morbidity for the patient. And so how do we manage this kind of situation? We try to block the progression as it is occurring. And the way to do it is by means of the corneal cross-linking. So there was this interesting realization that patient with keratoconus and patient with that have diabetes had a lower risk of developing keratoconus. And this was associated with a decreased risk of progression of the disease. And so different speculation about this. And the most interesting theory is related to the fact that as we get to the anatomy, as I said before, we have the stroma, which is the aspect that is most interesting for us. And in the patient with diabetes, they had some degree of natural cross-linking of the fibers. So had some degree of arrangement of the fibers that they are increased in rigidity, and so there is no deformation, conical deformation of the image. And this is really interesting, as diabetes is a protective factor for the development of keratoconus. So the main idea, the rationale, is that if you provide vitamin B2, which is riboflavin, and coupled with UVA light, we are able to block the progression of disease. This is happening because once UVA light is pointed towards a patient that has riboflavin on the anterior segment of the eye, we have an important process of covalent bonding at the level of the stroma. In particular, there are covalent bonding between stromal collagen fibers and between collagen and protoglycan fibers as well. As we said before, reactive oxygen species are fundamental because once we do this kind of procedure, reactive oxygen species are produced and they are responsible for this kind of cross-linking. This is the original paper. This is a really successful paper by Warren and Sack et al. It got cited more than 3,400 times, so it's been the original paper for the cross-linking procedure. But I want to show you the procedure itself. This is the Dresden protocol. And an important aspect to remember is that in this kind of original paper, it was shown that a really interesting percentage of individuals, so all patients that were treated with cross-linking, did not progress, did not experience any kind of progression in the pathology. And up to 70% of these patients had also improvement in the keratometry values. Also, there was a small percentage of individuals that also had a slight improvement in the visual acuity. But again, I'd like to underline the fact that corneal cross-linking is not utilized for blocking a progression, but rather to improve the visual acuity, but rather to block the progression and to arrest the progression of the disease. The original protocol is also known to be the Dresden protocol, which is the standard procedure, and I'll show you the video. So here, we have that the anesthetics is provided to the patient, topical anesthetic. At this point, the blepharospasm is introduced in order to improve the access. At this point, we have the important aspect to underline. At this level, we are performing scraping of the epithelium. So we have removal of the epithelium, which is fundamental for the procedure in the standard way. After the epithelium is removed, we also have positioning of the riboflavin, and it is coupled with the use of UVA lights. So we have the cross-linking of riboflavin plus UV lights, which is leading to the procedure of the blockage of the infection. After the procedure, we have the positioning of the lens, which is kept for a couple of days in order to protect the eye, which is from its protective layer. But again, the concept I like to stress is that this can be a little bit. Scraping of the epithelium is a quite, let's say, basic procedure. So it is also the most crucial aspect of the disease, of the procedure. Because once we remove the epithelium, we might expose the patient to a number of different conditions, which can be related to infections and also any kind of aspect of the external world that can be introduced into the internal world. And so in order to fix this kind of problem, there's been introduction of a new kind of procedure, which is the transepithelial cross-linking, which simply means that it is the same procedure but without removal of the epithelium. So the idea is that in this way we reduce the pain because we do not remove the epithelium, so it is less uncomfortable for the patient. And also we lead to a reduction in the post-operative infection because these patients tend to have a lower risk of infection due to the fact that the epithelium that acts as a barrier, as we said before, is not. Also, another advantage is that it is used also for corneas that are thicker that are less thick than 400 microns. So typically, the standard procedure cannot be done in patient with a pachymetry which is too much too low. Instead, in this patient, we have this kind of procedure, exploit this kind of procedure. Unfortunately, as fancy it might seem, there are some aspects that should be underlined. First of all, the results are not great in the sense that there is a return of baseline after 2 years, and also some patients, up to 50% of the pediatric patient, they require to redo the procedure. So we can speculate on this, on what is happening. Probably the most evidence-based theory is that if we do not remove the epithelium, we have also reduced efficacy because the stroma needs to be exposed to oxygen in order to be cross-linked. So there is a reduction in the exposure to this kind of aspect, less production of reactive oxygen species, and so most likely also less efficacy. So a really interesting solution to this is related to the iontophoretic transepithelial cross-linking. Again, this is quite a difficult word, it's a difficult term in order to simply describe the fact that we have the delivery of a small current of energy in order to perform the cross-linking of the fibers. Instead of removing the epithelium, we provide some degree of electrical current in order to block the evolution. I'll show you the video. So at this point, we have that the electrode is positioned on the scalp of the patient, and it is connected to the power source. At this point, we have the administration of the topical anesthetic. Also, we have position of the blepharospasm to access to the part of the cornea. At this point, we have positioning of a grid, which is interesting, the level of the central part of the cornea. And also, we have a syringe, which is used in order to aspirate air. So to provide the maximal adherence to the epithelium. At this point, we have the injection of the riboflavin. Again, since in this case the procedure is done in a patient that has not removed the epithelium, also the solution that is used is not just the riboflavin, but is a combination of different solution, including also EPA and other substances. So we have administration of the the solution. And also we have the application of an electrode. And so we have the riboflavin that is coupled to an electrical current leading to the cross-linking of the fibers. Of course, the patient is kept into place for around 5 minutes with the current is applied. So now I'd like to discuss a little bit about the results of this procedure and also the complications. So the results actually are really good. Also the papers after 10 years of follow-up of the patient that just recently came out, this kind of winter, is showing that the progression of keratoconus is around 10%. So it is a really good procedure. And also remember that this kind of patient were leading to penetrating keratoplasty. So a really invasive procedure with an important morbidity for the patient. And this way we can block the patient and arrest the evolution of the patient, providing also more time for the patient to avoid the progression. And also in the case of failure of cross-linking, it is also possible to redo the procedure. And so this is a procedure that can be also redone in this kind of patient. However, as I underlined before, when we have removal of the epithelium, we have some important complication, let's say, related to the pain, which is really moderate pain that only lasts for a couple of days. Then we have a transient corneal edema, again self-resolving and is only occurring in a small number of patients. And infectious keratitis. Infectious keratitis, there are just really little number of cases, accounted to be below 0.0017, something like that. So it's a really small number, and it is overall a really safe procedure. And again, we have the corneal haze, which is the most interesting one, because as you can see in the image, there is this kind of opacification in the central part of the cornea. And typically it is fading after 3 months, but there is some patient that unfortunately keep it for a longer period of time. Typically, within 1 year, the opacification is done. So the results are really good. And also it is a procedure that overall it has a really low number of complications compared to other procedures like keratoplasty or TAL. So just to sum up, to have an idea in general of the procedure. So keratoconus is a progressive disease which is typically occurring between the 2nd and the 4th decade. It is a disease that is progressive and is leading to penetrating keratoplasty in a large number of patients. And the introduction of cross-linking was a true innovation, is an innovative tool. It is combining UV light and riboflavin in order to stop the progression of the disease. This is the data for 3 years, but I can tell you that also after 10 and 15 years, the data is really good, and only around 10% of patients need to are progressing to an advanced stage of the keratoconus. Also, iontophoretic cross-linking could be a future treatment direction in order to improve the limitation that we said before. So thank you, and if you have any question, I'm glad to answer. Why riboflavin? So this is a really interesting question, and the riboflavin is a naturally occurring vitamin which is found also in processed food, so it is really widely occurring. And it was actually discovered by chance. There was no kind of rationale. They tried, and also it was based on the observation of diabetic patients. Yeah. Vai in italiano, poi la traduco in inglese, vai pure. Sì. Cioè si fa prima, so I'll repeat the question. So we have scraping of the corneal epithelium, and then positioning of the lens after the procedure to protect the eye from external agents. No, it's just positioned, delicately positioned on the eye, and is removed after 3 to 4 days. Okay. Perfetto, allora grazie e lascio la parola a Vittoria. Va bene. Grazie a tutti, buona serata e a presto.